Hi, my name is Dr. Carrie Bedient, and I am one of the fertility docs here at the Fertility Center of Las Vegas. We are the longest standing fertility center in the city of Las Vegas. We've been here for over 30 years now. There are three physicians here. Dr. Shapiro is our founder. He comes from Yale. He has done some really phenomenal research over the years that the research has changed the face of how IVF is practiced and how fertility medicine is practiced, particularly with respect to frozen embryo transfers and how you do those types of cycles. We also have Dr. Leah Kay. She comes to us from the University of Connecticut, and she is really phenomenal. She's a fabulous teacher. She's wonderful with her patients. She does a ton of reproductive surgery, and it's pretty awesome that we have her here. And then, of course, I am Dr. Carrie Bedient, and I do quite a bit of teaching. I'm the course director at the med school. I'm the director of reproductive endocrinology for one of the residencies in town. And of course, we all three of us lecture at the UNLV residency program as well. So have my hand in a lot of research and teaching. I do a podcast called Fertility Docs Uncensored, and so you may want to go for extra fertility information there as well. But what we're going to be talking about today is looking at when should you see a fertility specialist, when should you get a second opinion, and when should you really start to dive a little bit deeper into the testing and other things that you may need to find out what's going on in your reproductive system. So the definition of infertility is trying to get pregnant for 1 year without success. And there's a caveat to that. And that caveat is that if you are over the age of 35, they shorten that time frame down to about 6 months. And so when you're looking at trying to get pregnant, what I mean by that is having sperm available in the reproductive tract at the right time of month. And the best way to know when the right time of month is, or even if that's going to happen, is basing that off of the menstrual cycle. And so with the menstrual cycle, in a textbook perfect world, the cycle is a total of 28 days. So roughly the first 3 to 7, you have menstrual bleeding. And then around day 14 or so, you release an egg. And then if there's no pregnancy that month, on day 28, you're going to start bleeding again. And so that's a textbook cycle. Now, not everybody has a textbook cycle. Some women have cycles that are 30 days, that are 24 days, and there's variation, and that's totally fine. What we're looking for is something that's generally the same. So if your cycle is every 30 days and it's generally the same, give or take a day or two, then you can be pretty assured that you're probably ovulating every month. If your cycle is all over the place, so maybe every 3 weeks and then every 6 weeks, and then you go 3 months without it, you're probably not ovulating. And so you probably haven't had that opportunity to really try, but that's a topic for a little bit later. And all right, you should probably come see us a little sooner if that's the case. So 12 months of trying means that you know that you're ovulating, or you've got a pretty good likelihood of ovulating based on your periods, and there's sperm that's been available in the reproductive tract at the right time. Some people use ovulation predictor kits to help them out. You pee on a stick, it tells you if you're ovulating or not, and you go from there. What I'm typically looking for with that is making sure that your test is negative, your predictor kit is negative, then it goes positive for a short period of time, day or two, and then it drops negative again and it stays negative. So if you were to test every single day of that 28-day cycle, mostly negative, short positive, then drops back to negative, that tells us that the hormonal signals are working correctly. If you are someone who takes those ovulation predictor kits and they are never positive, or if they're always positive, or if they're mostly positive, meaning positive and then maybe negative, and then maybe positive again, then maybe negative, then positive, and they kind of stay up in that positive range, you can kind of just barely see the line. These are people who need to come see us sooner because there's some issue with ovulation going on, and we probably need to help things out a little bit in order to get you there. Now, when do you want to come see a fertility specialist sooner than those 12 months or those 6 months? If you know that you do not have regular cycles, we want you to come see us sooner. Now, some people don't have regular cycles intentionally, meaning they have an IUD in place or they're on continuous birth control. That's not what we're talking about here. We're talking about the people who aren't manipulating their cycle at all, and it just doesn't come. In those cases, we really want to see you sooner because we can help you ovulate and help move things along. Some people have known medical issues. And what I mean by that is someone who has a history of cancer and has gotten chemotherapy and radiation. For those patients, we want to see you earlier because there's been a known insult to the ovaries or eggs and to the sperm. And so whenever you've had that kind of insult, because chemo and radiation is fabulous for what it does. It is very effective at fighting cancer much of the time. However, it takes a toll on the reproductive organs, and eggs and sperm take a particular hit with those types of therapies. And so if you've had that kind of surgery, we want to see you sooner rather than later because oftentimes the numbers that we're working with are not normal. And so if we can get you sooner rather than later, we can start to work with that and freeze your eggs, freeze your sperm, freeze embryos, transfer earlier, whatever it may need to be in order to help move things along. When you have someone who has had surgery on any of the reproductive organs, a lot of the times they will need a little extra help and should probably come see a fertility specialist. Now, not always. That is not always the case, but it can be. And so things like for the guys, certainly if you've had a vasectomy and have gotten snipped, we need to see you because that's a procedure where you for sure going to need some help. We need to take the sperm out and do in vitro fertilization for that. A lot of people ask about IUI or intrauterine insemination after having had a vasectomy. It's not a good idea because the numbers are so very low and that sperm is not good at swimming. So you can get enough sperm out to do in vitro because you're directly combining the sperm and the eggs together in vitro. But in insemination, you still need at least 5 million sperm to swim up to where they need to be. And so insemination after vasectomy doesn't work very well. You really need to do IVF in that case. For guys who've had hernia repairs, usually that's fine. If a man has had testicular cancer, if he has had one testicle removed, oftentimes it's worth checking a semen analysis and just getting that reassurance that, okay, there's still enough there to get the job done. For the ladies, the reproductive surgeries that we really think about, there's a couple types. One is endometriosis surgery. And the reason I pay attention to people who've had endometriosis surgery is because that means that their endometriosis was bad enough that they had to go to the operating room to try and make it feel better. That means that endo is probably pretty bad. And we worry about the impact of endometriosis because endometriosis can destroy ovarian tissue and it makes for fewer eggs compared to somebody else of the same age. Endometriosis creates scar tissue. So sometimes the tubes can be blocked because that scar tissue just wraps around them and cuts them off so that the egg and the sperm can no longer find each other and have their little party. Endometriosis also alters the hormonal levels. So when I have somebody who's going through, IVF is the best example here because of the medications we use. If I have someone who's going through IVF who has endo versus the same woman who's going through who doesn't, I got to use much higher doses of medication to get that patient with endometriosis into a good spot with stimulating her eggs. Without endo, I can usually get away with less, but with endo, I have to give more. And so oftentimes you need a stronger push for all of that in order to help someone with bad endometriosis get pregnant. When someone has had fibroid surgery, we stop and pay attention. And the reason for that is because fibroid surgery can oftentimes impair the inside of the uterus. When we're doing surgery, fibroids, everyone should have a pocket uterus. I sometimes pull this out of my purse, and when I do, people look at me like I'm absolutely insane, but nothing beats a good model. So you've got your uterus here. And this is a vagina. This is the cervix or the entrance to the uterus. Tubes are over here. And then these white things are ovaries. When you're looking at fibroids, they come in a couple different places. You can find them here inside the cavity where that white one is dangling. You can find them in the wall of the uterus, or you can find them kind of partly within the wall of the uterus and partly pushing into the cavity. When you have fibroid surgeries, sometimes they can be really easy and you just have to remove this little dangling guy. You go up through the cervix and take it out. Those do not tend to do much damage. The problem comes when you've had these bigger surgeries, because this is to get this guy out, you have to cut into the uterus and pop it out. And fibroids can be quite large. I think the largest that I've ever taken out has been, roughly this size. And so they can do a lot of damage. They can create a lot of scar tissue, both inside the uterus and without. I don't really care about scar tissue outside the uterus. I care very much about scar tissue within the uterus. So we will do a hysteroscopy and we'll take a look at the inside and make sure that it's well behaved. We'll do ultrasounds and make sure that your lining's nice and thick. And so that's something where if you've had major uterine surgery, like a myomectomy, removing the fibroids, it's a better idea to go see a fertility doc because we want to make sure everything is good. We also want to make sure that the scar tissue from the myomectomy hasn't put your ovaries or in a weird position or blocked your tubes. Myomectomies are known for being scar tissue intensive surgeries. It's just kind of the way they are. And so we want to look into that. Age has another factor. And so if you are over the age of 40, we pretty much want to see you right away. Like, I don't care how long you've been trying, 2 months, certainly by 6 months, I want to see somebody who's over 40. In a lot of cases, I want to see earlier, because much of the time what I find is that when people really think about, well, how long have I been trying to get pregnant? It's for longer than you think. And the reason I say that is because in my world, if you are not preventing pregnancy, you're trying to get pregnant. So if you're not on birth control pills, using condoms, have an IUD, Depo, Nexplanon, whatever it may be to prevent pregnancy, if you're not on something like that and you're having sex, then you are trying to get pregnant. And so a lot of times when I dive into people's histories and I say, okay, how long have you been trying to get pregnant? Oh, we've been trying for 1 year. How long have you been together having sex? Oh, well, shortly after we got together, and that's been like 5 years now. To me, that means you've been trying for 5 years. And that's a very different story, because someone's like, all right, we really need to look into this. Like, this is not something that's likely to happen on its own at this point. It can, after 3 years of trying without success, it's about a 1% to 3% chance per month, but that's pretty low. And we don't want to just bank on that. We want to start pushing the issue so we can get to the family size you want. Of course, you need to come see us earlier if you know you are missing one of the components of things that we need in order to get you pregnant. So in order to get pregnant, you need eggs, sperm, uterus, and tubes. And many couples, for some reason or other, are missing one or more of these things. So one example would be if you had tubal surgery in the past. Let's say you've had an ectopic pregnancy and they've had to remove your tube. We want to see you sooner rather than later because we're worried about the function of that other tube. Let's say you've had both tubes removed. For sure, we want to see you because we know that there's nothing that's going to help the egg and sperm come together. Those tubes are gone. They don't have any way to get together. So we got to see you in that case. If you don't have a uterus, maybe you were born without one. Maybe you had to have surgery somewhere along the line, whether it's cancer surgery or fibroid surgery or whatever type of surgery, and you no longer have a uterus. Maybe you're a man and you were never born with one and need to work with somebody else's and have known that from the very beginning. Those are all reasons to come see us earlier in the process. The sooner you know what you want to do, the better, or at least have an idea like, okay, I'm thinking about this. The sooner you know how to work within that world, the better, because using a surrogate or gestational carrier to carry your baby is something that's done more and more commonly. However, it takes a lot of time and a lot of planning and a lot of work. So the sooner you start, the better likelihood you're going to have a good outcome. Sometimes we have people who don't have sperm or don't have eggs. And so those can be patients who have had chemotherapy or radiation in the past. Some of my patients who have significant diseases, even if it's just diabetes or high blood pressure, heart disease, autoimmune diseases. Sometimes it's from the disease itself. Sometimes it's from the treatment of those diseases where it's a really effective treatment, but it's hard on the eggs or hard on the sperm. Sometimes it's a permanent lack of the opposite. And so for my male couples and my female couples, they're inherently missing part of the equation. And so they know that they need to work with donors to achieve their family goals. So those are patients who we want to see right away. And that helps us to really get in. And the main things we want to do is we want to go through your history and we want to see, okay, what might not be working out? Because in our field, the sooner you start figuring out what could be going awry, the better your outcomes are going to be. Time is fertility. And for the most part, you're not going to fall off a fertility cliff at the age of, or after 1 month of waiting or 6 months of waiting, or in some cases, even a year. Typically with fertility, especially with women, there's just a gradual decline over the years. It's not like you hit the age of 35 and you fall off a fertility cliff. It's a gradual decline from the time you start getting your periods. And then as you hit 35, it gets a little steeper. And as you hit 40, it gets a lot steeper. So the sooner we can talk to you and go through the testing, the sooner we're going to know things. I definitely have patients who have been interested in fertility and they're just like, I just want to know my numbers. And they came in, we found out, oh my goodness, your numbers are a lot further off of where we thought they were going to be. Your egg counts are a lot lower. Your hormone levels are high or low when they really should be low or high. And there's something going on there. And so knowledge is power. And time is egg quality in my world. So the sooner we can do things, the better. Now, if you're young, under 30, we typically have a little bit of time. Between 30 and 35, depends on the size of your family that you ultimately desire, kind of depends on how much time we have. And over 35, the sooner we can get you in and get that information, the better, because it gives us an idea of, do we need to do something? Or can you be a little bit more reassured? And how do we want to approach getting your ultimate family goals? Now, when do you get a second opinion? So second opinions are something that we're very used to in the fertility world. It's very common for me to see someone who has all of their testing already done because they're coming from another fertility center. It's very common for me to have my patients want to go talk to somebody else because they don't like what I told them, or they just want somebody else to verify it. We're all pretty used to that as fertility docs. And it's something where it's helpful to get a second opinion if you think that something is kind of going awry, like if something doesn't make sense to you, if you don't fit in well with your fertility doctor. I mean, there is an element of personality. If you look at my 3 partners and I, the medicine we practice is the same. The way you get the information is a little bit different based on our individual styles. And so you get the same care. It's just how are you going to hear it? And pardon me. And some people hear information better or differently coming from different people. A lot of times getting a second opinion is helpful just because you hear another voice say the same thing over again. And that's really one of the key things that I found. And part of the thing that I appreciated about second opinions is because patients come in with more knowledge. And so they're able to hear what I'm saying to them a little bit better. So maybe the first opinion, they liked the doctor just fine. They want to make sure that whatever news they got, this is real. The vast majority of the time it is. Like, we're all looking at the same numbers and we tend to approach it relatively similarly, but there are nuances here and there. There are people who take on different type of treatments more readily than others, people who work within the research world more readily than others, and so have different approaches based on the information they're getting in. So when you get a second opinion, it's helpful to have as much as you can ready to go, because the more information I have in front of me and can skim through, the more information I can turn around and give you. And then you can decide, okay, do you want to stay with me? Do you want to go back to your original doctor, whatever. Usually docs should not pitch a high holy fit if you request your records and go somewhere else. We're used to it. Most of us have learned not to take it personally at this point. I know my first couple of years in practice, I was always heartbroken of, oh my gosh, they didn't like me. And now I know it's a part of fertility, because fertility is hard. You got to make sure you're gelling with the person you're with, and that you can accept the information that they're giving you, because in this world, we give a lot of bad news, and you need to know that the person who's giving you the bad news has done everything in their power to get you to where you want to be. And I think that's true for all of us here. I know we certainly take our patients very personally and get invested in what their outcomes are. So I hope this information is helpful. And let us know if you want to schedule an appointment. The phone number is 702-254-1777, or you can always go to our website and request an appointment that way. It's very helpful for us to go all the way through your history and decide what we want to do, how we want to do it, go through the results with you, talk about what testing is helpful. Most patients, we look at the full gamut of what they're going to do, or we look at the full gamut of what testing needs to happen. So I don't want to just look at the ovaries or just look at the sperm. I want to know how the whole system is working, because I have had patients come in where they have said, I don't get regular periods. And we can make the assumption, oh, she probably has PCOS because she's got a bunch of acne and her male hormone levels are high and she doesn't have a period. But I don't want to just assume that, because I can't tell you how many times I see someone who says, oh, I don't have regular periods. And we find out she has PCOS. Great. We kind of knew that. We could figure that out from her history. But we find out he also doesn't have very much sperm. Or we find out that her tube is blocked. And that dramatically changes how we approach things. So we tend to say, let's get all the testing, because it's going to give us a better idea of how we can best serve you. Because if it really and truly is just PCOS, where you don't ovulate every month, that's a very different medical approach than if someone doesn't have tubes, or if their sperm count's really low, or if they need surgery on their uterus. And so we want to know all of those things up front. One other category of people that I haven't yet talked about are people who have abnormalities that they either know about or that they find out about working with their gynecologist or the urologist. So these are things like an arcuate uterus, a septate uterus, a bicornuate uterus, a vaginal septum, abnormalities with where the male urethra comes out. Sometimes it doesn't come out right at the tip of the penis. It comes out here or lower instead. Sometimes there's communication issues between where the sperm is made in the outside world, where someone's had an injury or surgery or just a genetic abnormality, where they know that they're going to need some help because of structurally how they are put together. And those are things that with our testing, we're looking for. Do you have one of those abnormalities? And do we want to change it anywhere along the way? A group of people who should seek fertility help sooner rather than later are people who know that they carry some sort of genetic disease. And there's a couple ways that you can find this out. Family history is a really, really good one for that. Carrier screening is a really good thing for that. And so sometimes you find out through your family history, like, oh yeah, hey, 3 women on my mom's side have breast cancer, plus grandma had ovarian cancer, and somebody else has colon cancer. Maybe there's some genetic something going on here. Those kind of things are important to pick up on, because we can always send you to a geneticist and say, hey, go through our family history and find out if we need to look for targeted things here. There are other things that can hide. And so carrier screening is a really helpful thing to do before you try and get pregnant, because it can tell you if there's any sneaky genes that can combine and cause a big medical drama. And what I mean by that is everybody has 2 copies of a gene. If they're both normal, great. If they're abnormal, you're affected with whatever diseases. If one's normal and one's abnormal, it means that you are fine and your family is fine. But what can happen is if you and your partner carry the same abnormal, they can come together in a baby, and the child can be affected. And the things that we are looking for are big, bad, and ugly. They are diseases that you do not want and would not wish on your worst enemy. And so we look for those ahead of time, because if we find them, then we know, okay, we need to do some specialty genetic testing ahead of time to avoid passing them along in your child. or at the very least, you need to know that you need to look for that in your child once they're born or once you do get pregnant. And so much of the time, what we do is PGTM for those cases. That means that we are looking for a very specific mutation that can cause a disease like cystic fibrosis or like sickle cell anemia. So you can get that carrier screening either through us. A lot of the general OBGYNs offer it, and it's a good thing to do to say, hey, let's test me and my husband me and my partner, me and whomever is providing the other half of genetic information I need in order to make a baby. Let's test both of us and find what could potentially go awry so that we can deal with it before it's a major medical issue. There's also folks who are just worried about the genetics of their child due to age. So I have a lot of moms who come to me who are, 40 and older, and they're starting to run a higher risk of genetic abnormalities like Down syndrome, Turner syndrome, Edwards-Pattos, all of those things that happen when someone ages. And they say, you know what, I really would like a healthy child. I don't know that I can handle one that has special needs from the beginning. We'll deal with whatever we have later on, but I want to try and avoid some of that right off the bat. And so we'll do genetic testing on the embryos, and we transfer the ones that have the appropriate number of chromosomes. And we typically do not transfer the ones that don't. If we do, it's a ton of discussion. I have yet to transfer one knowingly abnormal. And so, when you transfer an untested embryo, of course, you don't know if it's abnormal or not. But once you have that testing, you can say, all right, there are 46 chromosomes, no more, no less. This is what it should be. So this is what we're going to transfer. None of this genetic testing changes the embryos. They are what they are, but it helps us to identify them earlier. And so we can help women get to a healthy pregnancy faster and avoid the miscarriages and avoid the negative pregnancy tests that are the most common outcomes. And in some cases, help them avoid termination of pregnancy later. I can't tell you how many ladies come to me saying, I got pregnant on my own, but we found out there was some major genetic abnormality and we had to terminate, and they're devastated. And so we can help to avoid that so that we get to a healthy pregnancy a little bit faster. Doesn't guarantee everything. Nothing does. You can't test for autism. You can't test for schizophrenia. There are plenty of things that our genetic testing will not pick up that only show up on ultrasounds or after the baby's born. That's not increased by IVF, but it's just the normal world we live in. And so those types of patients who need that extra genetic testing, it can be really helpful to go through that testing ahead of time and talk with the genetic counselors and really find out, what do we need to do? How do we need to get to the outcome we want? And do we need to do anything special? It may be you just go ahead and try the old-fashioned way, and that's your best way of getting pregnant. But those are a lot of the patients who benefit by fertility treatment a little bit earlier, and who benefit by second opinions. One final group is patients who want to family plan for the future. And this can be in the form of egg freezing. For a woman who hasn't necessarily met her partner yet, so she doesn't know whose sperm she wants to use, but she really wants to make sure she can have a pregnancy later in life. It can also be for patients who have few more years under their belt, who know that they want multiple kids. So for example, I have a patient who came to see me. She was, 36 years old. She really wanted about 4 kids. And she knew that she was going to be able to get the first one probably pretty reasonably based on her testing. But we kind of knew that by the time she got to babies 2, 3, and 4, she was going to be 38, 39, and then 41, 42, and then close to 45. And that we were going to start to hit more issues with helping her get pregnant. And so we did embryo banking for her, so that she and her husband could have those embryos for the future. And it would be less important what her age was at that time, because the uterus ages really pretty well. It can carry a pregnancy even later in life with minimal risks, as long as the woman is healthy. As long as you have a good embryo to put in it. There's far more risk associated with the age of the egg than there is with the age of the uterus. So not to say that it's risk-free if you deliver at a later age. It's just, it may not be as bad as you think it is. So So family planning is a large part of what we do, because if someone knows, I really want to have a family using my genetic material, but I'm not ready yet, or I am ready, but I want my family to be bigger than what I'm likely to easily be able to get, let's plan for that now so that we can hit the family size we want in the future. So kind of a summary. Reasons to come see an infertility doc. If you have been trying for 12 months or longer, and think about what the definition of trying is, it's not preventing it. We want to see you. If you're over 35 and it's been 6 months without a pregnancy, we want to see you. If you have any medical history that makes you think that you might have a problem conceiving, whether that is endometriosis, fibroid surgery, an ectopic pregnancy in the past, a bunch of miscarriages, chemotherapy, cancer treatment, all of those types of things. We'd rather see you sooner rather than later so we can start having a good discussion. If you have any abnormalities that you were born with your uterus, your ovaries, your vagina, your penis, anything like that, a lot of times a little bit of fertility treatment can help move whatever needs to move in the right direction. For patients who want a family plan, really helpful. For patients who know that they are missing one of the components for whatever reason, you don't have eggs, you don't have sperm, you don't have a uterus, you don't have tubes, those patients, the sooner you come see us, the better you know how to plan. Even if you don't do anything right away, you at least kind of know, all right, this is what I need to do in the future. For second opinions, really, there's never a wrong time to get one. It just kind of depends on the timing and what you're looking for. It is helpful when you come in for a second opinion to know what your question is, even if it's just what do you think? Can I get pregnant or can I not? And kind of know what you want to get out of the experience. Are you looking to change docs? Do you just want verification that your own doc told you a good plan? And certainly whatever you do, our goal is to help you get to the family you want and do it safely and happily. Please let us know if you need anything. We are here for you. Happy to see you for a consult and go through your history. Okay. Have a wonderful, wonderful day, wonderful evening. We will see you guys soon. Bye now.